Our next speaker is Dr. Raquel Moyses from the University of São Paulo, Brazil, and she'll present on the global incidence of HPV-associated cancer.
Well, good afternoon. Okay, thank you. It's a pleasure to be among so many renowned scientists. I'm Raquel Moyses. I'm a head and neck surgeon from University of São Paulo Medical School. I also belong to the GenCapo Genome, Head and Neck Genome Project from Brazil. I'm going to talk about the global incidence of HPV-associated cancer. This one? Here? Okay. So I have nothing to disclosure. First, I would like to address a very important question, in my opinion, which is why should we actually bother about the prevalence and incidence ratios of head and neck cancer associated with HPV? We have no doubt that for policymakers or also for researchers, this information is of substantial importance. But for us, as clinicians who deal with patients every time, do we really have to bother about the prevalence and incidence of head and neck cancer that are positive to HPV? And the question is yes, in several moments of our practice. First, addressing the question that should we always test for oropharynx or oral cavity cancers, should we always test for HPV, and also how to interpret findings, also positive and negative findings. Should we change our medical decisions only based on HPV testing results? And a tendency in clinical decisions and actually in decision-making in medicine is that to improve our outcomes of healthcare, we should keep in mind the prevalence of HPV-related cancer in our setting, our specific setting, and also to keep in mind the limitations of exams like sensitivity and specificity of the tests that are currently available in our settings. And also don't forget the burden of the testing results, not only economical but also social burden. So just to review a kind of new concept in medicine, in decision making, we have to be aware that for very low prevalences and also for very high prevalence, testing, when we deal with an imperfect test, might be actually not the best strategy. And it kind of relates to the sensitivity of the test, but mostly if we have, for instance, if you can see the last graphic with a test, for instance, with low sensitivity, it's better not to test in most prevalence ratios. So we should keep in mind that depending on the prevalence of HPV-related cancer in your subsetting, testing patients might be actually detrimental for the outcome. And that's why most of the promising biomarkers do not actually translate into clinically useful tests, right? We can see that mostly our positive predictive values may be very different depending on the prevalence of disease in our setting. So given this, let's go to the facts. If we are going to talk about the HPV prevalence worldwide, we know that most sexually active individuals who will acquire at least one genotype of anogenital HPV infection at some time during their lifetime. And there's great variation in the prevalence for several reasons, like anatomical site sampled, sampling methods, HPV DNA detection assays, and the duration of the infection. We know that most patients clear the infection. And we should always also keep in mind that the HPV prevalence is much lower in the oral cavity than in other anogenital sites. So these are data from the IARC regarding HPV prevalence in cervix of women with normal cytology of pap smears. And we can see a most important, a higher prevalence in women from Africa, but also in Latin America, and mostly in all the places. The most common type is HPV 16, which is associated with a higher risk of cancer. And when we're talking specifically about HPV related to head and neck cancer, we know that the fraction of oropharyngeal cancers and orocavity cancers that are positive for HPV varies substantially. And some reasons that we can point is that first, the accuracy in the distribution of in the distinction of oropharyngeal cancer, mostly due to misclassification, but also in case of advanced tumors that we can't actually precise the region of the tumor. And this may be more relevant in patients in developing countries where we have a higher proportion of more advanced stages. And of course, as a fraction, so we have to acknowledge the competing effect of tobacco smoking and alcohol also and chewing. We can't forget the quality of tissue biopsies and HPV testing protocols that are used, and mostly what are they actually measuring, if they're just addressing the presence of the virus or they're actually finding HPV that is incorporated to DNA and so has an actual role in the pathogenesis and the etiology of the tumor. Of course, we have very distinct sexual behaviors in different populations, and not forgetting the publication bias of very low prevalences of HPV. Oh, I'm sorry. So we can talk about several studies of varying degrees of varying findings of HPV prevalence. It becomes a bit difficult to compare them because, as we can see, we have different regions, geographic regions with very low prevalence of head and neck tumors that are positive for HPV, while others with extremely high prevalences. And when we try to compare them precisely in terms of the methods used, the type of sample, and what do they actually mean, it gets really confusing. So I'd like to point a very elegant study, in my opinion, which addresses mostly the incidence rates for orocavity and oropharyngeal cancers in several populations in the world. These data are from the cancer incidence in 5 continents from the International Agency for Research on Cancer, and they comprise more than 180,000 patients with oropharynx and orocavital cancers. They didn't test for HPV, of course, in such a huge sample, but the tendencies can reflect the potential role of HPV in this etiology. So most of these patients, of course, were men, and they collected not only oropharyngeal cancers, orocavity cancers, but also lung cancer data from patients from 23 countries around the world. And we can see here that some countries have more than one cancer registry system. And what we can see that the higher incidences among men of oropharyngeal cancers are from France, Slovakia, and Switzerland, and orocavity cancers from India, France, Slovakia, and Brazil. We can see higher incidence among women, just remembering that they're much lower than in men, for oropharyngeal cancer in Switzerland, France, and Denmark, and orocavity cancer in India, the Philippines, and Denmark, France, and Switzerland. Here we can see the trends in the incidence from 1980 to 2002 that were studied in this group for oropharyngeal cancer. Oh, I'm sorry. for oropharyngeal cancer in yellow, oral cavity cancer in blue, and lung cancer in gray. And if you're here, we have the trends in men, and here in women. And if we are to the right of the graphic, it seems like we have an increase in the trend, and if you're in the left to the graphic, it means that the incidence is decreasing. So we can summarize by saying that the incidence of oropharyngeal cancer significantly increased during 1983 to 2002 in several countries around the world, most apparent in developed cancer countries, among both men and women, which reflects the potential for increasing global relevance of HPV in these tumors. And we can distinguish three major patterns, and two of them are indicative of a dominant role for HPV. The first one is that when we have, an increase in oropharyngeal cancer incidence with a stable or decreased incidence in oral cavity cancer, and also a stable or decreased incidence in lung cancer. We can see this pattern in United States, Australia, Canada, Japan, and Slovakia for men. Slovakia only for men. Another pattern that reflects the potential impact of HPV in these numbers when you have an increase in both, in both oropharyngeal cancer and oral cavity cancer incidences, but the increase in oropharyngeal cancers are much higher than the increase in oral cavity cancers, with stable or decreasing lung cancer. That was observed in men and women from Denmark and United Kingdom. And a final pattern that suggests an actual effect of tobacco use and smoking and also drinking in these patients would be an increase in oropharyngeal cancer, but also in oral cavity cancers in similar rates. And this pattern was observed in Brazil and Netherlands. They also analyzed the data, the incidence trend in younger patients, which means a good news, less than 60 years old. And for pharynx cancer, we observed substantial increases in United States, Australia, Canada, Slovakia, Denmark, United Kingdom, and the Netherlands. And for cavity cancers, we could both observe significant increases in United Kingdom, but a significant decrease in United States, Australia, and Canada. I'd like to briefly show some of our most recent results of HPV in Hospital das Clínicas, which is the place I work. I'm going to be very brief. We used 369 head and neck paraffin samples of tumors. We could, as you can see in the distribution, we have a pattern of predominant sites of oral cavity and larynx, which reflects the use of mostly alcohol and tobacco. But we also had a sample of 24 patients with oropharynx cancer. We could successfully amplified 350 samples, and we could see 25% of our patients with oropharynx cancer were HPV positive. When we compare that to historical data from other places in São Paulo and Brazil, we are already observing an increase in this proportion. Most of the patients were positive for HPV 16. And I'd like to point a very interesting point that it's not only relevant for you to know the prevalence of your country, but also the prevalence of the profile of patients that you actually see. We have We had a clinical trial among 2 Brazilian sites, 2 Brazilian hospitals from São Paulo with different profiles in terms of patients that they see. One of them sees mostly private patients, and the other one only patients from the public health care. And in this clinical trial, they performed the HPV genotyping, and they actually saw all of the HPV positive cancers in the hospital that deal with private patients, which in Brazil is associated with higher socioeconomic levels. So that's important for us to keep in mind what is the profile of patients that you actually see in your practice. So just to summarize some of the more important characteristics of patients that are HPV positive that we should actually be concerned in our clinical practice would be patients with tonsil or base of tongue tumors that are usually younger, mostly men with high socioeconomic status and sexual behavior that are associated with an increased risk for HPV. So what are the implications of these data? Well, they can be several. For instance, vaccination to boys with the assumption of decreasing oropharyngeal cancer, it will surely depend on the profile of patients that you're trying for whom you are proposing this strategy. So in very low incidence areas, it's unfeasible and probably not cost-effective. Also, the screening for HPV in very high-risk populations. We just talked about screening partners of patients with HPV-positive tumors. As this prevalence is usually very low, the risk of having a false positive result is really higher. So what you're going to do with this result and how it's going to, what is going to be the burden of this test result for the patient. Also, in low-risk populations, let's say we have an elderly female with the gum oral cavity cancer that doesn't smoke and doesn't drink. Should we really test HPV for her? Knowing that the prevalence of HPV-positive tumors in this population is low, is this test really is really going to change our practice? And isn't it more likely to give her like a concern that may have impact on her social life and also in many aspects of of her moralism, let's say. So we should be aware, finally, in what is the prevalence in our population to properly interpret test results. Remember that the change in positive predictive value of the test and negative predictive value of the test is very often according to the prevalence of HPV head and neck cancer in the population that you're actually testing. So that's it. I would like to thank the opportunity for being here and talk to you. Thank you.
The literature has, as you and the previous speaker have said, wildly different rates of HPV from 0 to 100%, which is more suggestive that it's a technical problem than differences in population. Perhaps the difficulty is the FFPE itself. My suggestion is one of two things. Try it at least in some fresh frozen, or if you're going to do DNA and real-time PCR with a control gene. Just a suggestion.
Of course, we have very different patterns of quality of assays and the way that samples are actually preserved. So there are several issues. It's very difficult to compare them.